So welcome everybody, thank you for coming. Tonight, we plan to talk about some of the issues that confront elderly people and those people caring for them. So we're going to get started. I just want to give you a little bit of an overview about what we're going to talk about tonight. We're going to present a number of case scenarios, sample situations that happen to many different people. We're going to talk about how they can be managed, what can be done, and where to turn in Israel. We're going to present some information about something called geriatric syndromes, which we'll go into in greater detail a little bit later. But some of them are, we're going to talk about drugs, depression, dementia, delirium, and falls in greater detail. So, a couple of scenarios. You went to visit your parents, spent some time with them over the Chagim, and you notice that one of them is all of a sudden listless, apathetic, not showing interest in things, takes no initiative, and you kind of see that as a big change in their personality and you don't know what to do. They may possibly not remember your children's names, or they're having difficulty finding words, and that's a change from what you're used to. Another scenario, you get a phone call from a neighbor of one of your parents that, or relatives, were found wandering around the neighborhood, and they can't find their way home. What do? You travel to visit somebody who's close to you, and you find their fridge is empty, they're not taking their medications, you're not sure what's going on. Another case, somebody might fall and sustain a hip fracture, they're hospitalized, and now you don't know what to do because they're not functioning at the level that they were functioning prior to the fall. That's how you feel. Okay. So, what's unique about the geriatric approach to healthcare of older people? How is it different? And there are a number of major areas that have been identified. They're called the geriatric giants or geriatric syndromes that affect quality of life and the functioning of individuals. They're not diseases per se. They're conditions, and they're all interrelated, and they affect each other. So, let's go through them. One of them is incontinence, immobility. I think these terms are understood. Yes? Okay. Iatrogenesis is something that we do to people, like we as healthcare providers. Somebody might be hospitalized and they develop an infection while they're in the hospital. A drug is given, and they have adverse reactions to that drug. Impaired homeostasis is the normal process of aging where the systems of the body are less sensitive and they kind of slow down and they affect everything else. Immobility and falls, intellectual impairment, which includes some of the things we're going to talk about tonight, like dementia, Alzheimer's, delirium, depression. And all of these things are interrelated. So you see that these rings are all connected because one affects the other. And each one on its own can lead to other problems. And what we're really concerned about is how do they affect a person's ability to function on a daily basis? How does it affect one's activities of daily living, one's ability to be in the community, to be at home? Where does this person need to live? So, okay. Now I'm going to hand the mic over to Shelley, and she's going to, Dr. Sternberg, sorry.
That's okay, I don't mind. So thank you everybody for coming this evening. I see some familiar faces here, and thank you very much for coming. I'm a geriatrician, which means that I'm a medical doctor who specializes in the care of the elderly. Ashir is a geriatric nurse. I'm also an internist, and I run the memory clinic at Shari Tzedek. In addition, I'm responsible for geriatric services in Maccabi in the Jerusalem and the Shvela region. I just wanted to give you an example to highlight, because this is so important. We're going to use this as our framework for the rest of the evening. Okay, so you have some arthritis, osteoporosis, high blood pressure, a little bit of diabetes. How many people am I describing in this room? Right? Everybody, as they get older, has chronic diseases. So it's not that in the care of the elderly or geriatric care, it's not that we don't care about chronic diseases. We care very much. But what we care about is, how do all these diseases impact on your daily function? How can we, as a team, and as our team at the Memory Center, how can we improve your quality of life and daily function? So just to give you an example, the lady that I told you, 87 years old, she lives alone, she walks with a walker, she has arthritis, osteoporosis, hypothyroidism, an underactive thyroid, and hypertension. She takes a pill for her high blood pressure. She takes something for osteoporosis. She takes Acamol, 2 tablets 3 times a day for arthritis. And she wakes up in the middle of the night. She's a little bit confused. She's not sure if she already took her sleeping pill or not, so she takes an extra one. And then a little bit later in the middle of the night, she wakes up to go to the bathroom because, as we know, a normal change of aging, it's one of those little tricks that the creator of the universe did on us, which is, as you get older, your body gets rid of the water at night rather than during the day. So getting up 2 or 3 times to go to the bathroom is considered normal. So she gets up to go to the bathroom and she falls, okay, because of many normal changes of aging, like older people have a decreased righting reflex, so they can't, the body doesn't as easily right itself. She falls, she can't get up, she's lying on the floor till the morning, till her daughter calls, doesn't get an answer, comes to see her, and she ends up in the emergency room with a hip fracture. She has surgery, including a local anesthetic or epidural anesthetic, different shifts, medications for pain. She gets confused. They put her in a diaper because she can't move. And then a week later, the social worker comes and says, well, you know that she's CUD and she can't go home. So this is, I think, a pretty typical. CUD means she's nursing care. She can't walk. She's in a diaper. You know, who's going to take care of her? So I think this is a pretty typical case. And just to explain what we mean by these interacting rings. So this woman had all kinds of normal changes of aging. It turned out actually that she had a bladder infection, and that's what made her confused to begin with. Why she took her 2 extra pills, leading to her fall, her incontinence, and her delirium, her confusion because she was in a new environment, got new pills, etc., etc. Okay, is that clear? All right. Okay, so let's go back to the cases. So you spent more time with your parents over the Chagim or vacation, and you notice that your parent takes less initiative. They seem more listless, show less interest, and they can't seem to remember your children's names. So this could be any number of things, but let's examine a little bit. Could this be drug-related? Now, why would I be concerned? Remember iatrogenesis? That ring in the middle is all those things we do as healthcare providers to our patients. We give them drugs, we put them in hospital. So could this change be related to drugs? Now, why is drug use in the elderly so important? Well, people age 65, this is American data, so people age 65 are 13% of the US population, and they buy 1/3 of all prescription drugs. In Israel now, we're sitting around 10%. In Japan, it's more around 20%. Most of Europe, they're, really starting to panic. By 2040, 1/4 of the population in the United States will be over 65 and will buy about 50% of prescription medications. So because older people have more chronic diseases, they take more drugs, there's much more chances of interactions. And also there are drugs that are inappropriate as one gets older. So as you see here, you can see in dark purple is the percentage of people who are unable to care for themselves. In light purple are the percentage of people who have impaired cognition. And then in blue are the percentage of people who have impaired mobility. So this just shows you graphically, and this is Israeli data, that as the number of medications increases, doesn't matter what medications they are, the percentage of people who are limited in terms of the daily function, especially in terms of ability to care for themselves, impaired cognition, and impaired mobility, goes up. All right? So we usually say that, the cutoff is around 4 or 5 drugs, and you can kind of see that here. So in general, it's one of those axioms of care of the elderly is we try to minimize as much as possible how many drugs, and there are certain types of drugs specifically that are not recommended. Is that clear?
Yeah.
All right, so what are bad drugs for older people? Any drug that is what we call anticholinergic. There are many different systems in the brain to help brain cells communicate, and they're all based on chemical energy. So there are different chemical systems in the brain to help these brain cells communicate. One of those chemicals is acetylcholine, and there are many, many drugs that block acetylcholine, like antihistamines. What do I mean by that? Cold season is coming up. All those drugs like Coldex, Nucidex, those are all verboten, really asur in older people. Okay, because they're anticholinergic, they increase the risk for confusion and falls. The old anti-allergic drugs are antihistamines. Okay, so not the newer ones, the Lorestine and Zillergy, those are Allegra, those are better. But the older antihistamines, how many of you still remember Benadryl, right? And a lot of older people, not a lot, but I've had some patients who take Benadryl before bed because it's very sedating, and that's why it's not good for older people, because again, it increases the risk for falls, it increases the risk for confusion, all right? In general, there's some antispasmodic medications also that are not very good, and a lot of the sleeping pills and anti-anxiety pills, the Lorivan, Bondormine, how many, I won't have a show of hands, but Valium, I don't want to embarrass anybody, Valium, diazepam, or what's called in Israel Asival, one pill stays in an older person's body for 2 weeks, okay? So, all of those kind of sleeping pill drugs, as much as they're very beloved, and again, why are they beloved? Because, I'm going to take you back to those Olympic rings, there are normal changes of aging and sleep as you get older. Older people don't have more trouble falling asleep, and their sleep is less deep. Sleep has different stages. So sleep, the time spent in the deeper sleep is less. So oftentimes you'll wake up and you'll say, oh, I didn't really sleep. You slept, but it doesn't feel as restorative. So again, all of these drugs, as much as possible, we try to avoid. Clonex, also a popular one that's quite long-acting, we try to avoid as you get older again, because all of these drugs increase the risk for those Olympic rings, specifically for the confusion and the falls and even incontinence. So now we're getting to the part of, okay, so now what can we do about it? How do we access the system to our benefit to help empower ourselves and our family members around drugs? So first of all, in every kupa, the family doctor or the nurse can print out a list for you from the computer that shows exactly what's in the computer that you're taking. Now, what you have to do is take that list and go home and make sure that what's in the computer, the prescriptions that your doctors are giving you, is actually what you think you're supposed to be taking, okay? Bring your everything with you to the doctor once every 6 months. They call it the paper bag test. Everything. not just medicines, everything over the counter, from the health food store, anything for sleep, for constipation. Bring everything and ask either the nurse or the family doctor to go over it with you. Make sure that you're both on the same page. I really like pill boxes. I know some people don't like it. You know what I mean by those pill boxes? You set it up once a week. It has Monday, Tuesday, Wednesday, Thursday, Friday, morning, afternoon, evening. It's so easy for you to keep track of what you're taking when you're using a pill box. You just look down and you say, oops, I did or I didn't. Not to mention it makes it easier sometimes for your children and your family members and caregivers also to see. And again, I just wanted to reiterate here that, be proactive. Go to your doctor and say, I heard in a lecture that I went to that this drug maybe isn't so good for me. What do you think? Is there an alternative? So there's a lot of ways to empower older people in terms of medications and taking appropriate medications. The anticholinergics are a category unto themselves. There are many drugs that are anticholinergics, but the biggest culprits are the antihistamines. And I brought that up around this time of year because people think, I have a plugged nose, I'll take a little Coldex or a little Nucidex. It's not good, okay? All right. Now, same case. You spent more time with your parents over the Chagim and you notice that they're less initiative, listless, show less interest, and can't seem to remember their children's names. Now, what else could this be? Okay, maybe it's not a change because of some new drug. Maybe they're depressed. Okay? Now, I wanted to make a few points about depression. I think we've all sort of heard that depression usually is somebody who's sad and they aren't eating and they're not sleeping and they've had these symptoms for at least 2 weeks. But all that can be turned on its head as you get older. Some older people eat more when they're depressed. Some of us younger people too, but okay. Some older people sleep more when they're depressed. And most older people don't come to the doctor saying, I'm sad and depressed. They come saying, my back hurts, my head hurts, my shoulder hurts. It's often, we're talking about a generation where, psychology was less out there, less accepted, okay? So minor depression in older people is very common. What do I mean by minor depression? Again, people don't come in saying, over the last 2 weeks I felt really down in the dumps and I can't sleep and I can't eat and I have no interest and I can't get out of bed in the morning. That happens, but it's much rare. More often people just say, I stopped going to the classes I used to go to. I don't really enjoy getting together with my friends anymore and I find that I'm sleeping all day long. That's when the lights start going off. Could this be depression? And depression is very important because we know that it increases the use of healthcare services, it causes excess disability, it leads to poor health outcomes. We know that people who have heart disease who are depressed do worse just because of their depression. And it even causes increased mortality. So again, major depression is much less common as opposed to younger people where major depression is much more common. So again, I just wanted to put up here, I don't expect anybody to remember, but I wanted people to realize that today depression is very treatable. We realize more and more that depression is a sort of loss of balance of brain chemicals, and we have good drugs today. There's no drug in this age group that doesn't have side effects, but we have good drugs today that have manageable side effects, that we know the side effects. And I'm talking sort of as opposed to 20 years ago or 30 years ago. So I just wanted to give you a feel here for the kind of drugs that I think are good drugs. And again, in older people, we always say start low and go slow. I start with very, very low dosages. Sometimes when I have students with me, they'll say, but Shelley, those are homeopathic dosages. Well, it doesn't work like that because, again, as you get older, the way your body responds to drugs is also different. And the effect of certain drugs on the body can be more intense at a lower dose. So again, just to give you a few names, all right? If a person has depression with a lot of sleep problems, I like this drug called Miro, and interestingly, this drug is effective at low dosages to help sleep. So I usually start with 1/4 of a tablet, and oftentimes I don't go beyond that. Okay, if there are no sleep problems, more the person, as in our case, has no initiative and they're listless and they're just kind of sitting all day, then I'll use a drug that's a little more activating. And the ones that I like are this drug, citalopram. It's the grandfather of a drug you might have heard of called Cipralex. And I just like this drug better. It seems to have less side effects. By the way, I don't get any cut from any drug company here. This is just for information's sake. Sertraline is also not a new drug, and I like it because you can go up very high dosages. I start with half of the smallest dose, which is 25 milligrams, and if we need to, we can push the drug up to very high dosages without side effects. Sometimes families come to me and they say, you know, my husband just sits and stares. Okay, so there can be a lot of reasons for that. It happens sometimes after a stroke. It happens sometimes in the early stages of dementia, but there's things that we can do to treat that too. Interestingly, if the person does have heart disease, sometimes we use Ritalin. In kids, Ritalin calms them down, but Ritalin is actually an activating drug, and sometimes it helps. Bupropion is Zyban, which is used for smoking cessation. It's actually a very, very activating antidepressant, and as a side effect, they found that it helps stop smoking. All right, drugs to avoid, again, because they're very anticholinergic, are Paxet, Seroxat, the generic name is paroxetine, and the much beloved Prozac, fluoxetine. Again, these are my less favorite drugs in older people because, again, they're very anticholinergic and they can make people sleepy and confused and fall and et cetera, et cetera, et cetera. Okay? Okay, so let's say you have a family member who you suspect they're depressed. Where do you go? Where do you get help? So the first address is always the family doctor. So again, I'm a Canadian, so I grew up in a socialite, although I trained part of my training in the States. But I'm used to socialized medicine. I think one of the wonderful things here is that we have access to good primary care. All right, everybody has an address. The address is the family doctor. I have to share with you that I've worked in Canada, the United States, and Israel. The family doctors here are, by and large, very well trained, okay? So the first address would be the family doc. Family docs are trained how to treat depression. They know the drugs, okay? If you're not satisfied or if you think it's a little more complicated, then I would go for geriatric assessment, okay? I skipped over the social work. I'll get to that in a minute. What does a geriatric assessment mean? In my Kupa in Maccabi, if you come for a geriatric assessment, you'll have a multidisciplinary whole person assessment. You'll have a one-stop shop where you'll be seen by a doctor, a nurse, an occupational therapist, a physical therapist, and a social worker. And we look at the whole person, their environment, the community, etc., etc. So the whole point of geriatrics is to look at the whole person in their own milieu and not just as a list of medical problems. So again, the geriatric assessment is when you think depression might be part of some kind of bigger problem, like maybe this is the beginning of a cognitive problem, or maybe it's because of pain and we're not getting the pain under control, or maybe it has something to do with family relationships that are being strained for whatever reason. The social workers in the Kupa are very good resources to connecting you to different social outlets in the community, to connect you with the Rivacha, the welfare services, to let you know where the different, how do you say moadonim?
Day centers
Day centers might be. to help you figure out if you're getting all the resources that, all the benefits that come to you. If you're a Holocaust survivor in this country, you get a lot of benefits. They can help you and explain the process of applying to Bituach Leumi, and they can do some therapy as well. So the social worker in the Kupa is a great resource. Usually you just call up your Kupa and you make an appointment with the social worker, either in the doctor's, usually it's not in the doctor's office, it's usually in the SNF, in the main branch of the Kupa. In the last few months, since July, psychiatry has actually entered, and I entered the Kupa system, so it's entered the socialized healthcare system, which means now that every Kupa has psychiatrists who work for the Kupa, and you should be able to get a list of those psychiatrists in the listing of services on the internet, from your family doc, from the main information office from your Kupa. In addition, if you've already been seeing a psychiatrist, and that psychiatrist, let's say, is part of Tachana Libriyut HaNefesh, which is they had a nationalized system or a governmental system of psychiatric outposts in the community. Now those you can see through your Kupa. If there's still private psychiatrists that you have to pay privately, but the point here now is that you can see a psychiatrist through the Kupa, which you couldn't really do before. And again, a big part of treating depression is building a seder yom, having a schedule, to know that there's something to do in the morning, and then we can refer you to all kinds of social outlets depending on what you like. Your local community centers, your AACI, Milabev if your loved one has some cognitive problems, Ulpan, I could go on and on and on. So that's just to give you some sense of where you can actually get help for a person who has depression. Okay, now your neighbor's called to report that your loved one was wandering in the street, unable to find the home he's lived in for 30 years. Or you've traveled to visit your mom or your aunt or whatever for the Chagim and found her fridge nearly empty, her bills unpaid, and her house in disarray. How many people in this scenario would be worried? Very much so. How many people have been in this kind of situation? Okay, it happens. Not to this, obviously this is an extreme case. Okay, so what are we worried about here? We're worried about dementia. What is dementia? What's the difference between dementia and Alzheimer's? Anybody know?
Dementia at first
Okay,
stage.
so Alzheimer's is a kind of dementia. That's why Ashira and I like this slide very much. So dementia is an umbrella term, just like when you say heart disease. You can have heart disease because of hardening of the arteries, because you have a problem with the muscle of the heart, because you have a problem with the heart valves, because you have a problem with the heart rhythm. Those all in the general parlance would be called heart disease. So dementia is an umbrella term, which means, in a very sort of simplistic kind of way, that you have a problem with memory and a problem with one other area of cognition. What do I mean by that? What's another area of cognition besides memory?
Judgment.
Pardon? Judgment, exactly. What else? Language, right? Orientation. Okay, so you have a problem with memory, plus at least a problem in one other area of cognition, to the point where it impacts on daily function. And what do I mean by that? I mean, people come to see me and they say, my husband was a tax lawyer, and now when I put the tax papers in front of him, he just moves the papers all around, and he doesn't really seem to be able to know what to do with it. Or he can't balance our checkbook anymore. Okay, that's what I mean when I say impacting on daily function. The person is starting to need help. Obviously, in the advanced stages, the person will also need help in more basic things like bathing and dressing, but it usually starts with more advanced functions like managing money, managing medications, etc. So what kinds of dementia are there? The ones that we all know about are Alzheimer's disease, okay? And we'll talk about that in a minute. But Alzheimer's disease is the most common of the dementias. We say that Alzheimer's makes up about 50 to 70% of the dementias. But there are many other causes of dementia. The other most common cause, maybe about 20%, are strokes. Big strokes and mini strokes. Big strokes are obvious, when a person has a stroke and they have language problems or part of their body is affected and they have walking problems. Well, they'll also very often have cognitive problems. But people can have mini strokes too, and they might never be aware of it. And the only way sometimes that we know about it is that the person is starting to just get slower and no initiative, and the judgment is affected. So that's what we call vascular dementia. Vascular because it has to do with the blood system. It's hardening of the arteries. And then there are many, many, many other dementias which to us, because we run a memory center, are very important and very interesting, but less important for you. Parkinson's disease, something called dementia with Lewy bodies, which looks like Parkinson's but isn't Parkinson's. In other words, it doesn't really respond as well to Parkinson's medications. Parkinson's disease doesn't have cognitive problems usually till 10 years into the program, 10 years into the problem. But Lewy body dementia, even though it looks like Parkinson's, they have cognitive problems right from the beginning. So it's a different disease. And then there's something called frontal lobe dementia, which is a disease of younger people. It never happens over 75. And it's less a dementia of memory problems. It's more a dementia of horrible behavioral problems. Again, these diseases are all very, very rare. So when I talk about dementia here, for all intents and purposes, I mean Alzheimer's disease. Okay, so just a little bit about dementia. I like this slide. So if you see along the x-axis, we have progression of the disease in years. And then as we go up the y-axis, we have deterioration. So you see at the beginning, oftentimes, the first symptoms are mood problems. The person, it gives me a chance to have a drink. The family will notice that the person's just more into themselves, can sit around a whole Shabbos table and not say anything. Family will come and say, like we said before, I think he's depressed, and part of what we have to do as a team is figure out, is this depression or is this the beginning of something else? Oftentimes people are aware that something's not right, but they're not really sure what's going on, and it's depressing. And then we start to notice the memory problems, and you see as time goes on, and as we go up the y-axis, the memory problems get worse. In addition, there's functional autonomy, so we have functional deterioration. I want to point out here that there are behavioral problems. 70% of people who have dementia at some point in the illness will have some kind of behavioral problem. It usually happens in the middle to severe part of the disease or stages of the disease. And in the end, if a person actually doesn't die of heart disease or cancer, because those are the most common causes of death, then in the end, dementia actually affects motor function too, because so much of the brain is involved, so people will not walk and they won't talk and they'll have trouble swallowing. And usually what happens in the end is people die because they have pneumonia, because the food goes down the wrong way and ends up in the lungs. Okay, not a pretty picture, I'm sorry, but we'll end on a more positive note. The point to note here is that behavioral problems happen in the sort of moderate to severe stages, but at a certain point they end because the person is not able anymore to have behavioral problems. So I wanted to talk a little bit about behavioral problems because that's usually what causes the most challenges in caring for a loved one with dementia. But I like to give a framework first with what we call the 4 A's of Alzheimer's disease. 4 words that start with A in English or Aleph in Hebrew that, sort of characterize what Alzheimer's disease looks like. So people give me something and I'll translate it into A. What's the major problem?
Affect.
Pardon?
Affect.
Okay, affect is a good A, all right? It's not one of the characteristics, though, but affect or mood can be affected. Yes? Apathy, okay, same thing. It's not one of the major A's, but it could definitely be affected. It's one of the behavioral problems. Anxiety, also a behavioral problem. Aggression, all behavioral problems. So we're on the right track here. So the first thing is amnesia, right? Memory problems, okay? The second one is aphasia. What's that? Language problems, okay? So the way Alzheimer's speech sounds like this. You know, I went to that place, you know, where you buy stuff. I can't remember what it's called. The supermarket. And I went there in my car. So that's how it starts. And then when it progresses, it sounds something like this. I walked and it was so up there and beautiful, thank you. So Alzheimer's speech, there are words and there's even the cadence of speech, but you're kind of left scratching your head like, did I miss something? Because there's no logic, okay? So those are the language problems of Alzheimer's disease. Apraxia, what's that? What is praxis? There have to be some Latin aficionados here. What does praxis mean? Right. Okay, praxis means to do. So apraxia means that people don't know what to do with things anymore, all right? And we'll talk about some of the behavioral problems in a minute. So where does this manifest itself in daily living? Eating, exactly. You don't recognize how to use the cutlery anymore. Some people end up eating with their hands. What else? Dressing, right. If you don't recognize what a pants are for, then it's hard to know that you have to put your leg in there, not your arm in there. Okay? And then the fourth A is agnosia. Anybody know what that is? Agnosia is the inability to recognize familiar people and places. So I'm going to give you an example. Why is it so common that people with dementia are agitated around showering and bathing? Just use this schema and try and think about it.
Because they don't know what to do.
Right, so they don't recognize the shower. They don't know anymore what you have to do with soap. They don't recognize necessarily who their caregiver is, and then all of a sudden this person says, okay, get undressed. And deep down inside, getting undressed, because emotions are still preserved, because they're very deep, getting undressed is always a response of vulnerability. And a person with dementia, because they have language problems and cognitive problems, can't really express what the anxiety is all about, so they get agitated, okay? So that's why I kind of like this. I like to give this structure because it helps understand what you're seeing when there are behavioral problems. So the last component is not an A, but it's called executive function problems. Executive function has to do with planning and organizing, abstract thinking, judgment, making decisions. All right, like as we said before, like the lawyer who can't balance the checkbook anymore. Okay, so there's many different ways to categorize behavioral problems in dementia. Today they call them BPSD, the behavioral and psychological symptoms of dementia. I don't expect you to remember any of this, but just to know people can be aggressive. All those A's that you already said. Aggressive, agitated, apathetic. Some people have psychosis. They think that their caregivers are stealing from them, that their caregivers are having an affair with their spouse, that people are out to get them. Some people have mania. They talk nonstop. And some people get depressed, as we talked about before. So, where can you go for diagnosis and then management? Where in the system in Israel do you actually turn when you worry that your loved one may have dementia, or if they already are known to have dementia and you're having trouble. Okay, so what can you expect from the Coupa? Every Coupa has different services. Again, in many of the Coupot, a lot of the dementia diagnoses are made in these multidisciplinary geriatric clinics. In most of the Coupot, the geriatric clinic have a doctor, maybe a nurse, maybe a social worker. Again, and then the doctor, the geriatrician might send you to see an occupational therapist to do cognitive testing, to see a social worker to help you figure out what services are available in the community. They might send you to a physical therapist, and they might send you to a home care. Neurologists are also sometimes involved if it's not a straight garden variety, Alzheimer's disease. A lot of times in the Coupa, unless, excuse me for saying it because I'm in Maccabi, but unless you're in a Coupa that has a whole multidisciplinary team in one stop, you'll usually go from place to place. The quarterback, again, should be the family doctor. Sometimes the quarterback ends up being the geriatrician. Some people go looking for, before I go on. Every Coupa has a home care program, all right? They have home care programs in different models. So if your loved one with dementia is at the stage where they're bedbound, it's hard to get them out, they refuse to go out, they're stuck at home, then you can ask your family doctor to make a referral to your Coupa's home care program, all right? Again, Maccabi's home care program takes care of chronic patients. Klalit's program in Jerusalem is more based on sort of more acute care, people who are after hospitalizations. Meuchedet's home care program also takes care of some chronic patients. Leumit doesn't have that many older people, but they also have a home care program. So I'm stressing this because for some reason, people don't know. And again, you turn to the family doctor, and the family doctor has to make a referral. And then usually what happens is the home care team takes over, and there'll be a doctor, a nurse, a social worker, occupational therapist, physical therapist who will come to the house. Okay. Now, there are also many private services that do diagnosis and management. Because we're here from the Shaare Zedek Medical Clinic, I'm going to tell you about our service. So if you come to our center, our program is over 3 visits. On the first visit, you'll come and see a geriatrician who'll do a whole physical exam, get the story, go over all the medications. You'll see an occupational therapist who will, in an hour, do an involved battery of neurocognitive tests, pencil and pen. On the second visit, you'll see a social worker who will go into the whole family situation, and then a psychiatrist. Then the whole team sits together and we go over all of the information. Ashira is our nurse coordinator, and I'll get to her role in just a minute. And then on the third visit, the team comes back to the geriatrician and spends half an hour just going over the recommendations and how to make them happen. So if we recommend Milabev, we'll give you information on Milabev. If we recommend a medication, we'll give you information on that medication. We'll give you booklets, and we'll have you sit with a Shira who will do some teaching around, let's say, behavioral problems, and then we'll see you every 3 to 6 months and follow along and be there to help you and to navigate and to help you deal with any kinds of behavioral issues, eating issues, daycare issues that come up. So that's our service. I'm actually very proud of it. We have a great team. We also have a neurologist who works with us. She sits in on all our team meetings. She doesn't see every patient, but whenever we feel that a neurologist needs to be involved because we're not sure what the diagnosis is, she'll see the patients as well. Okay, so what services are available for dementia patients in the community? So Amutat Milabev, people heard of it? So Milabev actually won Pras Yisrael. It was started by Professor Arnold Rosin, who's one of the senior geriatricians in the country, and Leah Abramowitz, who's a senior geriatric social worker in the country. It's basically a network of pardon? Both are on our team, right? Leah Abramowitz is on our team, and so is Professor Rosin. Thank you, Shira. And it's basically a series of day centers that are specifically geared to dementia patients. They have a beautiful center for English speakers in Talpiot and a new building in Givat Masua. And they also have a program where they will send people home to work with your loved ones. The other thing that's nice is you can use hours from Bituach Leumi. If you get hours from Bituach Leumi, you can use those hours to pay for the time in Tel Aviv. EMDA, which is the Israel. When you apply to Bituach Leumi, should I go into this? Do people want to know? Okay, so let's say your loved one, yeah?
The difference between getting help from the Kupa versus Bituach Leumi.
Okay, you don't get help from the Kupa. The Kupa doesn't give help. Bituach Leumi gives help.
So
The home care is a medical service. It's not a personal care service. It's a nurse, a doctor to do medical care. Thank you for pointing that out. If your loved one needs personal care, they need someone to bathe them, to dress them, to walk with them, that's when you apply to Bituach Leumi. And Bituach Leumi does not care that much about what the medical problems are. They care how the medical problems affect function. And based on the functional needs of the person, how much help do they need, how at danger they are, do they need 24-hour help or just help during the day, have they already burned the pots, have they fallen down 3 times, are they incontinent. Bituach Leumi, a Bituach Leumi nurse will come and visit at home and decide how many hours of care the person is eligible for if they meet a means criteria. That means if someone has too much income, then they're not going to be eligible for Bituach Leumi. So the minimum is usually 9 3/4 hours or 5 hours, and then the maximum is 18 to 22 hours. If you're a Holocaust survivor, you can get up to 27 hours. And then and you can take those hours, let's say I think it's 3 hours that you get from Bituach Leumi, can be used to pay for a day at Milabev, okay? If you want to bring a foreign worker to live with your loved one, then you have to get the maximum amount from Bituach Leumi. You sign over those hours to the nursing company, and then, because each of those hours equals money, and then you pay the difference. It ends up covering almost half of what it costs to have a full-time live-in caregiver. I have to tell you, I'm Canadian, as I said, and I worked in the States. There's no other country that has benefits like this. If you look at all the OECD countries, Israel has the most long-term care in the community of any OECD country. That means that as a society, we still have a commitment to take care of our older population at home. Okay? Is that clear? Yeah.
When you're talking hours, are you talking monthly? You mentioned 27 hours.
No, 27 hours a week. A week. Okay. So that's Bituach Leumi. Yad Sarah also has exercise groups. They have support groups. They have all the equipment that you can borrow. They have all kinds of services where they will have a volunteer pick up laundry and wash it. It's a wonderful place not only to get services but to volunteer. They have a memory training program. Yad Riva is free legal advice that's in Yad Sarah for everything that has to do with guardianship and power of attorney. Also a wonderful service. And the Jerusalem municipality has a series of day centers that are run by the municipality. They have a hotline. I'll just refer you to this pamphlet that's put out by the Jerusalem municipality. It's only in Hebrew, but it says all the services that are provided for elderly in Jerusalem.
didn't explain EMDA.
EMDA is the Israel Alzheimer's Association. Amutat Dementia. So EMDA provides, they have support groups, they have conferences for dementia, they have all kinds of information. This is an information booklet. They have a wonderful suitcase full of different activities that you can buy, and it's a suitcase full of activities that you can take home and do with the older person who has dementia. You can look on their website. Okay, going on to the next case. Yeah. Oh, what do OECD countries? You know, all the European countries? All the European countries. I don't remember exactly what OECD stands for. Your loved one has neglected to take her diabetes medication, severely compromising her health. Could this be delirium? Now, when I say delirium, I mean a diagnosis of delirium. Delirium means sort of acute or subacute confusion because of something medical. What does that mean? Just to give you an example, okay? This is healthy older people who have had surgery. 50% of healthy older people, not people with dementia, have confusion after a hip fracture. 50% of people after cardiac surgery have confusion. They have delirium because of normal changes of aging in the body and all the organ systems, medications, new environment, no sleep, etc., 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 okay? So delirium is acute or subacute confusion that is usually reversible. So when I get a phone call from one of my patients saying, my mother fell, she had a hip fracture, she just had surgery, and she developed Alzheimer's disease in the hospital. Okay? Nada. There's no such thing. Okay? Alzheimer's disease is something that creeps up slowly over years. If there's a change from one day to the next in the level of confusion, or 1 week to the next, or a few weeks to the next, the first stop is the family doctor, because you have to make sure that there isn't a medical problem going on. So again, number 1, number 2, number 3 causes are drugs, for all the reasons that we've already talked about. Any kind of medical problem, again, constipation, dehydration, a cold, anything can tip an older person over, urinary tract infection, and environmental change, especially with dementia patients. The family will say, wow, all of a sudden he's more confused, and they'll find out that the caregiver went on vacation, okay? So any small change can cause an acute confusion. Again, the take-home message here is go to the family doctor. So again, where to get help in the Coupa. Now let's say this happens after hours. Every Coupa has a 24-hour line, usually staffed with nurses that you can call. It's in Maccabi, it's star 3555, and there's always nurses there to answer your call. There's Terem, which is the after-hours sort of walk-in clinic for problems that are acute but not emergency room level. Try as much as possible to avoid the emergency room. Emergency rooms are bad places for older people. You know, they get pressure ulcers because nobody turns them and people lie in one place. People don't get food, they get dehydrated. They don't turn off the lights at night, so people get confused. They often do tests that are not necessary. Okay, now with Shira.
Thank you. Okay, so now we're going to talk about falls. So we have a situation where we have your very independent loved one fell and broke his hip, making it impossible to navigate the stairs in his home. Okay, so as Shelley said, we talked about how all the rings are interrelated, and here we're going to see what could happen. So every 18 seconds, an older adult is in the emergency room because of a fall. That's a lot of people falling. Okay, what happens when an older person falls? 10 to 15% of falls by older adults result in some sort of injury, either a hip fracture or some other fracture. and very often it ends up in hospitalization. The death rate also increases as a person gets older. The more they fall, there's an increase in mortality, and it's the 6th leading cause of death. So what are the risk factors? Why do people fall? So we have 3 categories. They're usually multifactorial. Most people have a few issues going on simultaneously. So there are intrinsic factors, which are usually related to diseases like Parkinson's disease, where people have a shuffling gait and they might fall, or somebody who had a stroke and they're going to fall, or somebody with visual problems and they can't quite see where they're going and they trip. Extrinsic factors are drugs, and we discussed that earlier, the drugs that cause people to be sedated or cause confusion, and people get out of bed at night and then they try to go to the bathroom by themselves and they fall. And environmental factors like area rugs. These wires, right. Area rugs that are not tacked down to the floor very well. People get their feet caught under them and then they fall. Or poor lighting. Sometimes you have other obstacles. You have furniture in the way, or you have a cluttered home, and then people tend to fall there. Okay, so if someone falls, we want to prevent them from falling again, and certainly if they haven't fallen, we want to prevent that from happening. So what do? So the first thing is to stabilize the medical conditions. So if somebody has vertigo or they have postural hypertension, so that when they get up, their blood pressure drops, and then they get dizzy, and then they fall. So obviously the first thing we want to do is to try to treat those conditions to prevent that from happening. Okay? If someone's on medications that may be causing dizziness or any of these other conditions, so those need to be adjusted. Physical therapy can address a number of different things. So physical therapists are trained, first of all, to, I don't want to fall over this either. Physical therapists are trained to assess muscle strength and function. They can also assess what types of safety devices a person might need if they need an assistive device to walk, like a walker or a cane, and what type of walker and what type of cane. They can instruct people in aerobic exercises or strength training exercises. Most of the kupot, by the way, have a service where you can ask the family doctor to refer an occupational therapist to come into the home and do a home safety assessment or evaluation and tell you like what rugs you need to move, where to install grab bars, where you can improve the conditions so that you decrease the chances of falling. Excuse me. You also want to try to improve someone's balance, and Tai Chi is a great way to do that. Yoga sometimes as well. We talked about the appropriate aids, and hip protectors are padding that can be inserted into some type of undergarment that protect the hip areas so that if somebody falls, there's a lower chance of fracturing a hip.
And you can get them subsidized through the kupa, the hip protectors.
Okay. Where do you get help if somebody falls? What do? So obviously it's going to depend on the severity of the fall. It's going to depend on what happened in the fall. Now I just want to point out that with some of the conditions that Dr. Sternberg discussed before, not everybody is going to be able to say, I fell. You might find somebody who fell and got up, and you don't know that they fell. Or you might find that somebody has fallen, but they can't communicate that they're having pain. And so you have to kind of be a detective and be able to figure it out. If somebody's acting more aggressive or their behavior has changed. So we said before that it might be due to a medical problem. Sometimes it's due to a fracture. So if somebody fell and you suspect a fracture or you think they need to be evaluated, in this case, you really have to go to the emergency room. There's no choice, okay? It's not like going to Terem or the family doctor. You go straight to the emergency room. Now, the way the Kupot work here, for the emergency room visit to be covered, either the patient has to be admitted or you need a referral from a family doctor. So while you're on your way to the emergency room, you call the family doctor and you say, such and such has happened. Could you please issue a hafnaya or a referral? When they get to the ER, the person will be evaluated, have x-rays, etc., and they may or may not need surgery depending on the type of injury. And then you have the option of either using the doctors that are on call in the hospital or hiring a private physician. Most hospitals have a sharap, shiratim pratiyim, is that what it is? Shiratim pratiyim, and you can appeal to that office and you can get the name of a private surgeon if that's what you wish to do. Now, in the hospital, we want to prevent delirium. And how do you do that? Well, you stay on top of it, and you make sure that the person has their glasses and their teeth and their hearing aids, and you bring familiar pictures or maybe a familiar blanket or something to kind of remind them of their environment and their surroundings, a calendar, and very important, to sort of try to make a differentiation between day and night. So lights out at night, lights on during the day, that kind of thing. If you want to, you can request a geriatric consult in the hospital, or you can try to see if instead of being hospitalized on an orthopedic unit, your loved one can be hospitalized on a geriatric unit where they know how to handle hip fractures or other kinds of fractures, but they also know how to handle an older population. And they're specialists in that. Once the person has received the treatment that they need, it's time to start thinking about, well, what's the next step? Can this person go home or not? So we have to start with the discharge planning. And the two professionals that will help with that the most are the social worker in the hospital, and usually there's a nurse representative from the Kupa who is also involved in the discharge planning. And so we have to think about, well, where does this person live? Do they live in a four-floor walk-up, or do they live in an elevated building? Is there room for the wheelchair to get through the bathroom door or not? If they're using a walker, can they use it? Do they need physical therapy? Do they need rehab? What kind of rehab do they need? So there are different types of rehab. There's inpatient rehab where a person goes to a facility, an inpatient facility where they receive ongoing physical therapy and occupational therapy services in the hopes that they'll improve and be able to return to their former living arrangement. If not, then that also needs to be taken into consideration. Well, what next? Rehab can also be done on an outpatient basis, and that might mean going to the Kupa for physical therapy treatments 2, 3, 4 times a week, depending on what's ordered by the physician. Or in the case of somebody who's homebound, we addressed before Tipulei Bayit, the home care division of the Kupot. So many of the Kupot have a service where physical therapy will come to the house and work with the person at home as well. And then Bituach Leumi was addressed. I'm not going to go into that again, but it applies here as well if a person needs personal care, even if it's a short-term need, okay? What we were discussing before about Alzheimer's and dementia and that kind of thing were long-term needs. This might be a short-term need. So we gave you an overview today of some of the geriatric syndromes. We talked about dementia, depression, delirium, polypharmacy, and how it affects all these other conditions and falls. And we talked about navigating the healthcare delivery system in Israel. Thank you for coming.